From MicrobeTV, this is Infectious Disease Puscast, episode 95, recorded on Monday, December 8th, 2025. Hello, everyone. I'm Dr. Daniel Griffin, and joining me today is Dr. Sara Dong.
Hi, everyone. I'm Sara. I realized I should have sat in front of it. I just put my Christmas tree up, so that was the one thing I was going to share. But for those who aren't watching, Daniel looks like he's very cozy and in the mountains right now.
I am cozy. I'm up here at 11,000 feet at Mount Hayden Backcountry Lodge. What a great day. I saw some moose, and then we saw a bunch of elk, and then we arrived here up at 11,000 feet, and there was a pine marten, just beautiful, beautiful. And and somehow we're recording, which is amazing.
That's a much nicer view. I feel like my view has mostly been PowerPoints and emails and Epic. So, well, welcome everyone to another podcast. References, as always, are available in our show notes at MicrobeTV, the home of our growing multimedia empire. Podcast is a review of the infectious disease literature for the last 2 weeks that we found interesting or entertaining. So, on to the literature, shall we?
All right, we'll start with viral, and remember to listen to TWIV, This Week in Virology, both the clinical update and the deep dive. And the plan is to record the update from here. And by then, the place is going to be warm. I'll be wearing a T-shirt. I'll take off the parka. But all right, so we have some great articles. Actually, I feel like we're viral heavy this time, which is great, right? So the article, Early Low-Dose Dexamethasone is associated with shorter acute symptom duration in chikungunya virus infection, a retrospective cohort study published in BMC Infectious Diseases. So here they retrospectively analyzed 187 adults with confirmed chikungunya virus and severe arthralgia. 39 received dexamethasone 4 milligrams per day for 3 days. And this was started within the first 48 hours of symptom onset. And then 148, just standard of care, didn't get those 3 days of dexamethasone. Primary outcomes were duration of the acute febrile phase, duration of rheumatic manifestations, and they got this information, abstracting it from the records and patient reports. They also had some secondary outcomes, including C-reactive protein, adverse events. The dexamethasone group had a shorter acute febrile phase, actually significantly 3 versus 5 days, so a couple days shorter, almost half as long. And really what we were looking at, rheumatic manifestations, 7 versus 10 days. At late follow-up, the median CRP was lower, 20 versus 35. Adverse events were uncommon and really didn't see much difference in GI discomfort as a side effect. So might be something to think about adding to the acute treatment.
Yeah. I grabbed this paper from the New England Journal of Medicine, non-inferiority of 1 HPV vaccine dose to 2 doses. So this is a new double-blind randomized controlled trial, ESCUDO, ESCUDDO, published, as I mentioned, in New England Journal, demonstrating that 1 dose of the HPV vaccine was non-inferior to 2 doses in preventing HPV type 16 or 18 infection. And, just a reminder, and for context, that about over 3/4 of the global burden of cervical cancer is attributable to these HPV types of 16 and 18, but only about 27% of adolescent girls worldwide have been vaccinated. This trial randomly assigned girls 12 to 16 years old from 200 plus districts in Costa Rica to receive either 1 or 2 doses of the bivalent HPV vaccine. So that means it just has 16 and 18, also known as Cervarix, and or they were randomized to receive 1 to 2 doses of the nonavalent So Gardasil 9, which includes 6, 11, 16, 18, 31, 33, 45, 52, 58. I would not have known that off the top
Is
of my
that
head.
like known, like 9-valent? That's why it's called nonavalent? Like it's 9-valent versus I'm just thinking that there were nine serotypes there. Gardasil 9. I'm going with
That's
that.
what I was assuming.
Okay.
They're looking at their primary endpoint, which was new HPV 16 or 18 infection occurring from month 12 to month 60. So they followed them for 5 years and persisting for at least 6 months. So over 20,000 participants were enrolled and randomized, and they had 4,880 that were assigned to 1 dose of bivalent or 2 doses. So that's 2 groups of a little under 5,000. And then 4,851 for the groups that received either 1 dose of Gardasil 9 or 2 doses of the Gardasil 9. I'm going to say it because that's a little easier than nonavalent.
Nonavalent?
So after the 5 years of follow-up, we found that a single dose of either bivalent or nonavalent HPV vaccine provided similar protection to that of 2 doses, with that protection persisting at least through 5 years. And that effectiveness against HPV 16 or 18 infection was at least 97% efficacy. So that's preventing persistent cervicovaginal HPV infection. And so just additional strong evidence to support the WHO recommendation for 1 or 2 vaccine doses for girls and women to prevent cervical cancer. There have been some prior clinical studies already showing that a single dose can be immunogenic and effective and durable. And there's a large number of at least over 80 countries who have adopted single dose regimens as a primary immunization strategy. And something that I learned, the mechanism is pretty cool as far as why a single dose regimen might be so effective. And apparently the HPV vaccine subunit has these non-infectious virus-like particles, and they assemble into capsomeres and then into this sort of larger outer viral capsid and basically create an analog of the native whole virus without replicating DNA. And that structure is just very immunogenic. So just a little cool bit of science. I'm sure has come up on TWIV already. And Jenna, you could probably talk more about it, but I thought that was very cool.
Actually, I talked about this article because it's so great. And
yeah, I figured.
What I sort of like complained about, this is what the CDC is supposed to be talking about. Like, hey, maybe we can go over to a single shot HPV. Maybe we can move forward instead of like, oh, let's just disassemble what exists and spread misinformation. So, but let's get
more on that next.
More on that Thursday night. Okay. So the article Daily Masnodenvir, that doesn't roll off the tongue, as dengue prophylaxis in a controlled human infection model, published in the New England Journal of Medicine. So boom, 2 New England Journal of Medicine articles in a row. So check this out. These are the results of a phase 2A double-blind randomized trial where they assigned healthy adults to receive oral Masnodenvir once daily as a low dose, and then they're going to give a medium dose, and then they're going to give a high dose. Keep your eyes on the high dose, or they're going to do placebo. Loading doses were given for 5 days, maintenance doses for 21 days. Now, they do a controlled human infection model. All right, so participants received subcutaneous inoculation of an under-attenuated dengue virus serotype 3. When they get this on the day of the first maintenance dose, so day 1, the primary efficacy endpoint was the dengue virus 3 RNA load assessed as the log area under the concentration time curve from day 1, so immediately before inoculation through day 29. So you're going to get this area under the curve day 1 through 29. The high dose and placebo groups were compared in the primary endpoint analysis because, by the way, the high dose was the way to go, as we'll learn. Safety, pharmacokinetic features, virological, serological features were evaluated through day 85. But let us walk slowly through these results. Because you sort of have to do this backwards, right? So I'll be careful and go slowly. So the percentage of patients without signs of dengue 4 infection for the low dose was 0%, right? I mean, you don't want 0%. You want to see some people. So low dose, nobody's benefiting. Then you go to medium dose, about 17% of people actually have no signs. But then you actually get up to the high dose, 60% of folks have no signs. So 60% without. And then if you look at placebo, well, everyone has signs, right? So 0% are symptom free because they're not getting anything. So the high dose, you move forward. So the high dose also led to a significantly lower RNA load than placebo. They actually did a two-sided. They probably could have done one-sided, right? You're just saying, is it lower? But anyway, they do a two-sided. You get a p-value of 0.001. So really, really persuasive. They qualify in this small trial. Mosnodenvir did not result in any serious adverse events, right? Really small. We're not going to really see anything at this level. Plasma concentrations increased, and then were maintained through day 21. And now this gets interesting. I think it gets interesting. Among participants with available NS4B sequencing data, emerging amino acid variations, so sequencing, right? So non-synonymous changes in the genetic code that lead to amino acid variations in the NS4B region of the dengue genome and that coding area were detected in all, basically 14 of 14 of the folks that got drug, none of the placebo. Now, we care about this NS4B region because how's the drug work? Well, the drug is also known as J&J 642-81802. That's probably more familiar to, I'm joking. This antiviral is an oral pan-dengue serotype, small molecule antiviral drug, right? It's going to work on all the different dengue serotypes. And the way it works, it blocks viral replication by inhibiting the interaction between the dengue non-structural protein 3, NS3, and the non-structural protein 4B. And they have this really nice figure where you can actually see all the different, the impact. Low dose isn't doing much, medium dose, not much, high dose where you really start to see the impact. And then they do time to detection of dengue type 3 RNA. Again, really nice Kaplan-Meier curves there. So good stuff.
Very cool. So as I am sure many podcast listeners have raged about in recent days, thank you to those who tried to sort of fact check as the meetings were happening. The ACIP voted on Friday to end the long-standing recommendation that all newborns receive Hep B vaccine at birth, suggesting that parents discuss with doctors whether to administer it or wait until the baby is older. So there was a JAMA viewpoint published that I just thought I would point out if people wanted to take a look at, entitled Universal Hepatitis B Vaccination at Birth, Risks of Revisiting the Recommendation. And so the authors review the history of this policy, the risks of rescinding it, and I'm not going to focus too much on some of those historical details and data because I think a lot of folks who are clinicians are aware of this and you can check it out in the paper. But I did just grab the figure that they created representing the subset of mothers with acute or chronic Hep B, and just to walk through kind of what they were pointing out that, under the current standard of care, universal Hep B birth dose, we project, this is the author saying we project 625 perinatal Hep B infections annually. Eliminating the birth dose for infants of Hep B surface antigen negative moms as proposed would raise the number of cases to 674, an 8% increase. And so they have a red circle here in this diagram. And then restricting that birth dose to only infants born to Hep B surface antigen positive mothers would raise perinatal Hep B cases to about 1,100. So that would be an additional 63% or a 76% increase from current. And so their projections are a bit higher than those reported to the CDC. I'm preaching to the choir, but I just figured it wouldn't hurt to have additional voices that continue to say Hep B vaccine birth dose is safe and effective and an important tool. And I wish we weren't having to use so much energy to talk about things like this.
Yeah, no, this is so tough, Sarah. And don't worry, I'll be preaching to the choir again when we record Thursday night. There's an incredible, CIDRAP went through 400 articles, just all the evidence. And I think the fact is not everyone gets tested. Not everyone knows. The testing's not 100%.
Exactly.
This change is going to result in babies getting lifelong infection. And then, it's like 90% of those babies are going to go on to have, basically all kinds of horrible outcomes. So this is that, as I say, when you mix politics and medicine, you end up with dead babies. And this is it again. So this is really, really upsetting. But okay, I have actually something positive, something exciting. All right, Sarah, I see that smile on your face. So
we talk about
still...
sometimes positive things, just not
Yes,
as much recently.
It's going to get better. Okay, so this article, correlates of HIV-1 control after combination immunotherapy, published in Nature. Complicated stuff, but okay. Here, these researchers performed a single-arm proof of concept study in 10 people with HIV on ART. And they combine, so they're going to combine the following 3 approaches. So number 1, therapeutic vaccination with an HIV gag conserved element, followed by administration of 2 monoclonals and a toll-like receptor 9 agonist during ART suppression, followed by repeat monoclonal antibody, neutralizing antibody administration at the time of ART interruption. And what did they see? 7 of the 10 participants exhibited post-intervention control after stopping ART, independent of residual monoclonal antibody plasma levels. Really exciting, but also really complicated. So I wanted to walk a little bit through this, right? So first, they're going to select these 10 people. It's not just random, right? It isn't just take random 10 people and do this. So phase 1, single arm, the folks had to be on ART. So people with HIV on continuous ART for greater than 13 months. And then you're going to have 3 groups. You're going to have a group, had acute, so at N of 3, early, so when they started ART, and then chronic 3. So 3, 4, 3, acute, early, chronic. And then they screen. The CD4 positive T cells had to be at least 500 cells per microliter. No phenotypic resistance to the neutralizing antibodies that we're going to look at. So now we've got these 10 people. And a really nice figure kind of walks you through exactly when they do the therapy. So stage 1, the concept is you're going to boost and generate new HIV specific memory T cells, right? So that's that vaccination we talked about. And they're going to be getting these, you start 0 and 4 and 12 and 20. And you're also going to be getting this sort of, prime boost type approach. Then stage 2, the idea is to reduce the reservoir and then immune activation. So here's when you're seeing not only the monoclonals, but as far as the immune activation, this is the TLR9 agonist. So monoclonals, TLR9 agonist, monoclonals. And then stage 3 is this slow rate of rebound or promote host immunity. And that sort of, I guess I'll say this, the stage 3 part of this. And they follow this and just really, I say exciting, like at this point, a little more than proof of concept. So.
Very cool.
All right.
We did say the viral section was really robust today. I have 2 more, guys. Hang in there.
We warned you.
So MMWR, which of course it's nice for us to be able to pull papers from that. This is human-to-human rabies transmission via solid organ transplantation from a donor with undiagnosed rabies. U.S. October 2024 to February 2025. Some folks may have heard of this. I feel like it popped up in some of my maybe news emails, but this is the 4th transplant transmitted rabies event in the U.S. Since 1978. In February 2025, the CDC confirmed a fatal rabies case in a patient who had received a kidney transplant from a deceased donor with undiagnosed rabies. So the recipient patient had developed tremors, lower extremity weakness, confusion, and urinary incontinence about 5 weeks post-transplant. And then within 7 days after symptom onset, that patient was hospitalized with fever, hydrophobia, dysphagia, and autonomic instability. This patient ultimately died 51 days after their transplant, and later investigation revealed that the deceased donor had been scratched by a skunk about 6 weeks prior to death. And then there was also rabies virus RNA detected in the donor kidney, confirming organ-derived transmission. So no other organs were transplanted. I think the heart and lungs went to some sort of like research type thing, but not to recipient. But there were 3 people who received corneal tissue grafts. And so those 3 cornea recipients had graft removal, received post-exposure prophylaxis, and have been asymptomatic so far. All right. And then I, for this next part, grabbed a pair of papers that were both published in CID. The titles I'll just, I'll mention them here. So, cytomegalovirus specific cell-mediated immunity for prediction of post-prophylaxis CMV disease and a phase 3 trial of letermovir versus valganciclovir prophylaxis in donor CMV seropositive recipient, CMV seronegative kidney transplant recipients. So that was the first one. And then the second one is entitled An Analysis of CMV-Specific Cell-Mediated Immunity in a Phase 3 Randomized Placebo-Controlled Trial of Letermovir Prophylaxis in CMV seropositive recipients of an allogeneic hematopoietic cell transplant. So I'm going to try to summarize these, and I just thought it was important to pair them and present them together. So the latest international consensus guidelines for CMV management in our solid organ transplant recipients recommends CMV-specific cell-mediated immunity, or CMI, testing to help try to personalize the duration of antiviral prophylaxis. And then it's also mentioned as a potential area of application in some of the latest stem cell transplant guidance as well. So the idea here is, we often give a fixed duration of antiviral prophylaxis to patients, but can you prematurely stop prophylaxis in patients who have sufficient CMV-specific cell-mediated immunity versus continuing with that antiviral in those patients who have not developed that specific immunity? And so, and of course, this would be in the scenario of someone who is CMV seropositive, who's getting their transplant. And then just to point out, oftentimes people are using letermovir prophylaxis for at least 100 days after stem cell transplant, and then valganciclovir for 3 to 6 months if they're doing prophylaxis if it's a solid organ transplant recipient. But of course, there was a relatively recent study with the use of letermovir in kidney transplant recipients. And so in this issue of CID, they took these 2 studies that looked at that predictive value of CMV-specific cell-mediated immunity testing at the end of specifically letermovir prophylaxis. And so these are kind of sub-studies of those 2 phase 3 randomized trials. And so the first paper by LeMay and others is a post-hoc analysis of CMV-specific cell-mediated immunity using the quantiferin CMV assay. So this is looking at that pivotal trial I mentioned that compared letermovir with valganciclovir for CMV prophylaxis in donor-positive, recipient-negative kidney transplant recipients, where the conclusion is that letermovir is non-inferior to valganciclovir in preventing CMV infection, and it had a better safety profile. I think we probably talked about it on Puscast back when that original paper came out. And so when they looked at the CMV-specific T-cell immunity, they found that it was largely absent at baseline, 1.2%, which makes sense. These were CMV recipient-negative recipients. A small percentage developed CMV DNA anemia and CMV-specific cell-mediated immunity during their prophylaxis period, and that was higher in the valganciclovir group, so 12.8% versus 2.2%. And after stopping prophylaxis, a similar percentage of patients in the letermovir and valganciclovir group mounted CMV cell-mediated immunity by week 52. Those numbers were 28% versus about 29%. And so I have one of the figure 4 that looks at these quantiferin CMV testing results over time, kind of split up in the kind of teal color here for letermovir and the pink burgundy color for valganciclovir. To kind of summarize that the CMV cell-mediated immunity using this test, that quantiferon CMV, increased over time, but it really had a poor sort of clinical utility for us being able to predict post-prophylaxis CMV disease, which was driven by a couple things. A majority of patients with a negative quantiferon CMV result at week 28 didn't develop CMV disease by week 52. So that's about 83% of patients. Very small proportion developed a positive quantiferon CMV result at that week 28 point. And there was a relatively high incidence of CMV disease, even among those with a positive result at week 28. And that assay performance didn't really improve when they pooled the negative and indeterminate results. So even though the positive predictive value was high, the incidence of CMV disease among those with a positive result was not significantly lower than among those with a negative result. So 9.4 versus 11.7%. So, the results of the test kind of showing that looking at the end of standard prophylaxis didn't really seem to be clinically useful to guide decision-making on CMV prevention strategies. So that's a solid organ one, kind of bundle that up, put that to the side. And then our second paper, this looked at the trial evaluating the optimal duration of letermovir prophylaxis and hematopoietic stem cell transplants. So these were CMV seropositive patients who received letermovir prophylaxis through day 100 post-transplant. And then they were randomized 2-to-1 to either get another 100 days of letermovir versus placebo. And that study, when it was published, found letermovir prophylaxis up to that 200 days post-transplant reduced the incidence of clinically significant CMV infection from 18% to 1.4%. But that early benefit that they saw did not stick around at the 1-year mark. So that was not statistically significant at that later check-in. And so this current paper that I pulled is a post hoc immunologic evaluation of a subgroup of patients in that trial. And they found no significant difference in CMV-specific cell-mediated immunity between the arms when both had received letermovir up to the 100-day mark. So about a third of those patients had a positive quantiferon CMV result. Then when they looked at the next 100 days, the percentage of positive quantiferon CMV results increased across both groups, but was lower in those in the letermovir group. So if they took letermovir through day 200, that number of positive quantiferon results is 48.8% versus placebo was 75%, give or take. So some delayed quantiferon CMV positivity in the letermovir group. But similar to that original paper, at the 1-year mark, those assay positive rates were comparable between the groups. It was 66 versus 75% letermovir to 200 days versus letermovir at 100 days with that extra 100 days of placebo. So demonstration of how prolonged viral suppression during prophylaxis delayed but didn't really permanently prevent the development of CMV-specific T-cell immunity after stopping. So that was a lot, I know. But both of this pointing us to say that these cell-mediated immunity assays like quantiferon CMV didn't reliably predict future CMV infection in high-risk populations, which is what we're really the folks that we were hope to use it in. But anyhow, a lot to break down and summarize. Hopefully folks can dig a little bit deeper on their own time, but hopefully I gave as concise a summary as I could figure out.
So what do we do, Sarah? Do we just stay on it forever? What is what's the next step?
TBD.
Okay. All right. Well, the bacterial section, be sure to listen to TWIM, This Week in Microbiology. The crew over there continues to have some exciting stuff. I sometimes worry they're really popular. They really have a lot of listens, so you can listen to us and then share our stuff. Anyway, all right. So I enjoyed this, right? So this is, I don't know how many people have been following this. back and forth. But, usually the IDSA and the American Thoracic Society get together, we guidelines, everyone gets along. Didn't really happen this year. So we have the article, Infectious Diseases Society of America, IDSA position statement, why IDSA did not endorse the Community-Acquired Pneumonia Guidelines 2025 update published in CID. There's a piece like right before it where they talk about like, oh, we agreed on so many things. But I like this is why we didn't agree on those last two. So now the American Thoracic Society recently released updated community-acquired pneumonia guidelines, CAP guidelines. And the IDSA agreed with 8 of the 10 recommendations in the guidelines, but declined to endorse the guidelines because they include recommendations for use of antibiotics in outpatients with comorbidities and inpatients with non-severe CAP who test positive for respiratory viruses. It's noticed in the guidelines that bacterial co-infections are common and that delaying antibiotics may be harmful. IDSA notes, however, that non-discriminatory use of antibiotics for patients with CAP and positive viral assays confers more risks than benefits. Most patients do not have bacterial co-infections, and briefly withholding antibiotics for patients with non-severe illness to clarify the diagnosis is safe. In this era of precision medicine, IDSA instead recommends individualized, dynamic decision-making that takes into account each patient's evolving trajectory, severity of illness, and balance of clinical features for and against co-infection. Now, I did want to read this. This is like right from the guidelines. I'm going to read this quotation. And maybe I'll just say before, like the first 8 were good. It was a lot of like, use these antibiotics, all the shorter duration that we've come to love and know are evidence-based. But here I read. In the guidelines, it is noted that there are no randomized trials or high-quality observational data to guide the decision on whether to give antibiotics to patients with CAP and positive viral assays. In particular, it is stated in the guidelines that there's no evidence that it is safe to withhold antibiotics for patients with viral pneumonia. IDSA notes, however, that the converse also holds true. There are no data that show that giving antibiotics to CAP patients with positive viral assays is helpful. However, whereas the potential benefits of antibacterial therapy for CAP patients with viruses has not been established, the risks of antibiotic-related complications in hospitalized patients in general have been well established. They include C. diff colitis, organ damage, arrhythmias, drug-drug interactions, allergic reactions, microbiome disruption, and selection for antimicrobial resistance. Close quote.
Excellent. I just grabbed this other, it wasn't JAMA. This is from JAMA Network Open. Lyme disease incidence in Massachusetts 2012 to 2024. I, of course, am in Massachusetts, so that also partially biased me to grab it. But, this study looked at EHR-based surveillance data of over 1 million patients from 5 Massachusetts practice groups. And initially, if you look at their sort of overall chart, there's a suggestion that there's been a substantial decrease in Lyme incidence over this decade. But when they looked a little bit closer, that decrease was actually driven by one large group that had implemented a QI project to reduce Lyme disease and prescriptions for positive screening tests, but negative or pending confirmatory tests. And so I grabbed some of those line charts that you can see here, kind of just the overall cases, and then they are separated out this additional practice group. And you can kind of see the very clear separation in those lines. So the success of that initiative may explain that impression that the incidence was decreasing. And also just like a good example of how a practice-specific change can impact our perceived population-level disease trends. So pretty interesting. So even though the byline and the graph may suggest that it's going down, I think that's probably maybe too simplistic of a description of what happened here.
All right, I love that. All right, fungal. So the article, Aspergillosis Attributed Mortality in the United States, Analysis of Death Certificate Data, published in CID. Here they analyzed data from the U.S. National Vital Statistics System for 2018 to 2024. They found that there were 7,063 aspergillosis attributable deaths identified, with 22% listing aspergillosis as the primary cause. An invasive aspergillosis diagnostics code was most often listed, more than half, 4,880 certificates. Unspecified aspergillosis was listed on 2,139. Aspergillosis deaths actually increased in later years of analysis. But a little bit who's dying of aspergillosis, nearly 60% of the deaths occurred in folks 65 or older, and age-adjusted mortality rates were higher in males, 1.64. I also have another. I guess I'm stealing the fungal section here. This one is really interesting, right? So I'm going to ask people to sort of put in their bets ahead of time. So the article, oral itraconazole versus oral voriconazole for treatment-naive patients with chronic pulmonary aspergillosis in India, the Victor CPA trial, where that comes from, a single center, open label, randomized controlled superior trial was published in the Lancet Infectious Diseases. So basically we're asking the question, what's better, that old fashioned itraconazole or the fancy new voriconazole? What are you thinking? What are you thinking? Okay, put your bets in. So here we have a single center, prospective, open label superiority trial conducted at the chest clinic of a tertiary care hospital in Chandigarh, India. How do you pronounce that? Do you know, Sarah? Chandigarh?
I'm not sure.
Okay, I'm going with Chandigarh, India. People write in. They enrolled treatment-naive adults aged 18 or older with chronic cavitary pulmonary aspergillosis or chronic fibrosing pulmonary aspergillosis. Participants were randomly assigned 1-to-1 to receive 200 milligrams twice a day of oral itraconazole or fancy new oral voriconazole for 6 months. And they did this with, the variable block size randomization. End up randomly assigning a whole bunch of people, and they give us the demographics of, what percent were women and all the rest. Now, the proportion of participants achieving a favorable response in 6 months was actually similar in both groups. 69 for the fancy new voriconazole, so 69% for fancy new voriconazole, 67% for tried and true itraconazole. But voriconazole was associated with significantly more treatment-related adverse events, so 55% versus 34%. And there were 4 deaths all in the voriconazole group, but none directly attributed to the treatment. So I know those guys at the CDC and FDA can apparently directly attribute cause and effect in these huge studies, but here we did not see it. Okay, parasitic. Be sure to listen to This Week in Parasitism. I feel like you grab so many viral papers up front, Sarah.
I know.
So I'm just going to finish this off with our parasitic. I'm going to record This Week in Parasitism out here. I might go down to lower altitude because I'm, the breathing, 11,000. This is a little tough for an old guy like me. But anyway, so be sure to listen to This Week in Parasitism. And again, this is like a surprising article. You really got to keep reading, because if you get it entrenched in there and then new data comes out, you start realizing, I'm teaching something that's not true. So the article, Loa encephalopathy following treatment with benzidomazole derivatives. That's stuff like mebendazole and albendazole, right? A systematic review published in Open Forum Infectious Disease. So this caught my eye because, as I mentioned, it challenged one of those pearls that we like to teach that might actually suffer from being incorrect. So loiasis, a filarial vector-borne disease, is common in rural West and Central Africa. Benzimidazole derivatives, albendazole and mebendazole, are recommended as alternative treatments due to their perceived safety in hypermicrofilariamic patients. However, we read here that there's growing evidence that benzidimizoles might also lead to Loa associated encephalopathy. So we've been teaching that for Loa with high filarial loads over 8,000, First, one should lower the microfilarial load before using DEC to avoid severe adverse reactions such as encephalopathy and death. We might do this with apheresis. This is this blood filtering procedure. That might actually be the way to go, by the way, or initial treatment with one of these benzidimazole derivatives, so albendazole or bendazole for 21 days to reduce the parasitic load to a safer level. Once the load's reduced, then we jump in with ivermectin, followed by DEC to target the remaining microfilarial and adult worms. Now, treatment-associated encephalopathy was historically first reported after the administration of DEC, which was used on a large scale, relatively unregulated in the first half of the 20th century. Since the implementation of mass drug administration programs with ivermectin for the control of onchocerciasis in loiasis coendemic areas, ivermectin is known to similarly cause loa-loa associated encephalopathy. Now, in this systematic review, they analyzed all available evidence of benzimidazole-associated encephalopathy and actually report 6 potential cases of associated encephalopathy, including 2 fatalities among microfilariamic loiasis patients. And then go through all the details, but just sort of raising this issue that it may not be as safe as we thought. So we probably want to think about teaching that Pearl.
Cool. All right. Well, that brings us to the end of this podcast. As always, the references for this show are available at MicrobeTV, the home of our growing multimedia empire.
You can find the Infectious Disease Puscast at Apple Podcasts, microbe.tv/Puscast, or grab it with your favorite podcatcher or on YouTube. And then make sure to subscribe, like us, ring the bell, and leave flattering comments. We'd love to get your questions, comments, and paper suggestions. Send them to puscast@microbe.tv. If you like what we do, or you just want us to keep doing it, consider supporting the science shows of Microbe TV at microbe.tv/contribute. Or Parasites Without Borders, we're having our big fundraiser for Microbe TV. Go to parasiteswithoutborders.com and click on the donate button.
I'm Sara Dong. You can find me on Blue Sky at Sara Windong or over at Febrile Podcast.
I'm Daniel Griffin, and you can find me at Columbia University Irving Medical Center or at parasiteswithoutborders.com, as well as on the other podcasts, This Week in Parasitism and This Week in Virology Clinical Updates. Or I guess this week you can find me at the Hayden Backcountry Lodge up here at 11,000 feet in Colorado. All right.
Looking for visitors.
And as always, thank you for this most interesting consultation and allowing us to participate in the care of this most difficult and challenging case. We shall continue to follow along with you. Thank you, and dictation, and goodbye.
Thanks for listening. We'll be back in 2 weeks. Another Puscast is infectious.